It's our great pleasure today to have Dr. Gilad Kuperman as our distinguished speaker. Dr. Kuperman earned his MD from Albert Einstein College of Medicine and his PhD in biomedical informatics from the University of Utah. He has practiced as a general practitioner for a number of years in California and then Hawaii. And after that, he devoted his career in informatics. And currently, he's the director of interoperability informatics at New York Presbyterian Hospital. He's also an associate professor with the Department of Biomedical Informatics at Columbia University. He serves as the board chair and the executive director of NYCLIX, which is the New York Clinical Information Exchange, which is a regional health information organization in New York City, and he will explain how this is important for a number of important initiatives in healthcare. Dr. Kuperman also currently serves as the chair of the American Medical Informatics Association, AMIA, and he's also a fellow of the American College of Medical Informatics. His research interests include clinical decision support systems broadly and also evolving models of interoperability. He has published more than 60 peer-reviewed articles related to health information technology. And his talk today is entitled Health Information Exchange to Support Analytics, Opportunities and Challenges. So we're so happy to have you here and eager to listen to what you have to tell us today.
Great. Thank you very much, Constantine. Pleasure to be here. Pleasure to be here. As Constantine mentions, one of my roles is board chair of AMIA, which is the American Medical Informatics Association. And in that capacity, I get to think about the field in general. And you know, I think it's a very exciting time for medical informatics. The challenges in healthcare are so large, and the opportunities with the increasing amounts of data are so prescient that thinking about how to get the most out of the opportunities that we have today with respect to data, I think is very exciting. As Constantine mentioned, my career has been in clinical information systems. I've done a lot of work with clinical decision support, understanding how to try to get these things into the workflow, understanding what are the kinds of underpinnings around that, what kinds of vocabularies and terminologies do you need for that, how do you evaluate these things, how do you decide whether they're making a difference or not, using these things for measurement. And then, more recently in my career, working on interoperability and trying to have data available not just in one provider organization, but have it move across organizations as another way to get benefit out of the technology. And just more recently, I think the advent of a lot of computational techniques that are being developed and applied to healthcare data just kind of adds another very important capability to just the set of opportunities that we have by managing and analyzing healthcare data. So all these things, just take all these things together. I think it's a very exciting time in medical informatics. A lot of need, a lot of possibility, and I know folks at NYU here are working on these kinds of things. So I congratulate you and encourage you on those things. I'm going to talk a little bit today about some of my perspectives on some of these issues, and be eager to have then some conversation about it. So I thought I'd just kind of structure my remarks in these areas. So just talking a little bit about data and what are the new opportunities and some of the challenges that come come with that. I thought I'd say a few words about patient-centered outcomes research because this is an important policy direction for the nation and will be an important focus of research over the next decade or so, and just make some comments about that. Talk a little bit about some projects that AHRQ funded with respect to creating infrastructure for comparative effectiveness research. And it's a little bit different because AHRQ usually doesn't give out money for infrastructure kinds of things, but I think there was a recognition that some of the new directions going forward would require some new capabilities and some new learning, and so they invested in this in a substantial way, and I think there'll be some important lessons coming out of that, so I thought I'd say a few words about that. Say a few words about phenotyping, which I think sometimes gets overlooked, especially in the clinical domain. Oh, the patient has congestive heart failure. Of course, we know what we mean by that, and we know who the patients are who have congestive heart failure. But it's kind of not that simple. And say a few words about that. And then lastly, say some words about health information exchange and how health information exchange relates to some of these principles. But I thought I'd, from my perspective at least, lay out what I think are the relative, the relevant contextual factors before diving into health information exchange per se. So with that as background, so more data available, that's a good thing. So biologic data, I don't work with genomes and functional genomics and things like that myself, but many of you do, and clearly that's just a tremendous source of data, is new techniques for getting biologic data. Increasingly, there's capture of data from EHRs, and I say here and liquidity, meaning interoperability. So there's more with the meaningful use program and that incentive program. There's EHRs that are going in more ubiquitously nationwide, and with some of the interoperability aspects, it's easier to move the data from point A to point B, and that includes demographics, which is data about patients, records of healthcare encounters, just the fact that they happened. And there's data that comes from ancillary systems, laboratory data, pharmacy, radiology, nursing, things like that. Some of that data is structured, some of it's narrative text. And then there's the clinical documentation, also some of which may be structured and some of which may be narrative text. And then next, there's also the specter of patient-entered observations and capturing data directly from patients, patients' perceptions, patients' activities of daily living. Some of this is very nascent, but there's a lot of folks who believe that there's kind of a tidal wave waiting to happen about data that might come from patients themselves, and this would add to the whole just data set that's available for analysis. So if we're going to do analytics in healthcare, there's a lot of different ways of looking at this, and and I think that there's more similarities here than there are differences. But the first is, what are the methodologies for doing analytics? And if you're going to do prediction or classification or, regression, trying to infer things from large sets of data, there needs to be techniques to do that. It's a very active area. I know it's an active area here at NYU, and much more to be done there, certainly necessary. Then, just in some things that Konstantin has written, this concept of downstream informatics, linking molecular data to phenotypes, and again, a lot of opportunity there, understanding what kinds of, gene sequences are predictive of certain, physical issues, problems, drug responses, and things like that. A lot of opportunities there. And then, then comparative effectiveness research. So understanding, from treatment data, what works, under what conditions, and for what kinds of people, and doing these kinds of analyses. Again, large data sets with idiosyncrasies all of their own. Patient-centered outcomes research and comparative effectiveness research got a bit of a bad rap when it was kind of tied to making this or conceivably being used as a rationale for withholding care, and being tied to death panels and things like that. And so part of what patient-centered outcomes research does is it tries to move away from some of the bad branding that comparative effectiveness research has. But as we'll talk about in a minute, there are some aspects of it that are truly patient-centered. But there again, trying to bring improving evidence for decision makers, patients, clinicians, policymakers, improve the evidence that they have for decision making. And then lastly, in payment reform in healthcare, there's a general principle here that applying the evidence, doing evidence-based care and doing the most cost-effective care will be rewarded under new and evolving payment models. So provider organizations that might not have been had incentives to use evidence previously now will have incentives to do that. And so a couple of issues here. First, what is the evidence, and creating the models for what is best care, and then figuring out how to apply those. The latter is certainly non-trivial, and figuring out what the interventions are. But there's an implication here that to support evolving models of healthcare, the payment reform, that best practices will need to be known and be understood, and that will come out of some of these analytic approaches. So just a huge spectrum here of the kind of work that needs to be done using these analytic techniques. But some of the general principles apply across all of these. And so some of the challenges are coming up with the robust models to do the inferencing and the prediction about what the evidence is, getting data along the continuum, for some of these payment issues, knowing why the patient is seeking care, understanding the interventions, outcomes, status, functioning, experience, and then being able to describe the actual patient conditions and with the phenotypic data. These are informatics challenges. There are other kinds of challenges as well, which we'll talk about in a moment. But these are some of the hurdles to realizing some of the benefits. So just to say a few words about patient-centered outcomes research. So this is research that's informed by patient perspectives, interests and values, and it goes the gamut from identifying the research questions up to disseminating the results. So the idea is that all of this should be informed by the patient's perspective. It's intended to be practically relevant, and that the impact on patients would be known. And we kind of know why we're asking the question. We know what we're going to do with the answer when we have it. I mean, to put it crassly, these are questions that are not bench science questions. These are questions that are directly applicable to patients. And this is some of the quotes here from the around some of the descriptions of patient outcomes research. Given my characteristics and preferences, what should I be doing? What will happen to me? What are my options, benefits and harms? What can I do to improve the outcomes that are most important to me? And how can the healthcare system improve my chances of me getting the outcomes that I prefer? So these are some of the framing concepts here around this. And some of you may be aware there's a patient-centered outcomes research institute that was created. This came out of some of the Recovery Act funding. It was set up as an independent, not-for-profit corporation. There was a question about whether this should be done under the Agency for Healthcare Research and Quality, but decision was made to have it be a separate not-for-profit corporation. This enables certain things. So for example, like AHRQ themselves can't go out and survey patients without a, like, paperwork reduction act kind of a thing. They can't ask more than 9 questions at a time, but something like an organization like this can actually go out and do surveys and things like that. And they've got a decent funding stream. So some of it's up in the air, but it'll be approximately $500 million per year for through 2019. And they've laid out their draft research agenda. They've got a program in terms of identifying priorities and things like that. But this is their near-term research agenda. So certainly they want to assess treatment, diagnostic, prevention options, improving healthcare systems, focusing on communication, dissemination, addressing disparities. But this last one here, accelerating the research, the methodological aspects of research in general, and focusing on data, focusing on training, and focusing around the methods for carrying out this kind of research. And the premise here is that for this organization to do its work, randomized controlled trials won't work. With RCTs, you're relying on volunteers. The trials are of short duration. They're underpowered for many effects. They're too expensive. Sometimes you can't do them for practical or ethical reasons. The secondary use of data by this research agenda is implicit. And so if you take that last, this number 5 here, accelerating the methodologic research, this is kind of what that blows up into. So it's research on validity and efficiency of data sources that can be used to create a national infrastructure for this patient-centered outcomes research, improving the amount of data, the completeness of data, the comprehensiveness of data, the accuracy and efficiency of data collection, supporting data collection that's either patient-reported or patient-centered, engaging patients and engaging clinicians. So that's the aspects that this part of their program is going to focus on. And they talk about a high-quality infrastructure for this kind of research. Again, the amount of data, the completeness of data, making sure that there's high-quality data, that the data are valid, consistent, sufficient detail, and also that there's a variety of exposures. So if everybody's getting, let's say fluoride in the water, then you can't determine which one is better. So ideally there'd be some variation in the exposures that you're interested in, and there'd also be access to the patients. So if as a result of the secondary data analysis you kind of identify some interesting questions, you maybe want to go back and do some prospective trials. So if you have access to that kind of an environment, that's also viewed as desirable. And actually that first sub-bullet there, those are kind of highly important attributes of the infrastructure. Additionally, you'd have patient engagement in the governance, clinician engagement, and then, as I mentioned, opportunities for experimentation. So, in the payment reform era, understanding what works best is going to be important, and this is going to be one of the important vehicles to getting us there. So, just to shift for a moment, so I want to say a word about these projects that were funded by the Agency for Healthcare Research and Quality, also using Recovery Act funding. And the idea here was that these projects should create an infrastructure for comparative effectiveness research, kind of before comparative effectiveness research had its bad name. But the idea is the same, And I think there was $100 million that went to these 3 programs that were managed. So one was Prospect, the Prospect program. These are 6 programs that were targeted at doing prospective comparative effectiveness research studies, and really creating the infrastructure to do that, a data infrastructure, a governance infrastructure, a policy infrastructure that would enable these things to go forward. The second program was enhanced registries for quality improvement. And these would be able to track things over time. And then scalable distributed research networks. So if you were going to have a research network across a broad geographic area, how would you do that? And there were 2 of those. So there were 11 of these projects altogether. And there was a 12th project, which was called the Electronic Data Methods Forum. And the idea was that these other 11 projects were going to be generating lessons about how best to do this, and there should be a way to disseminate this information. And so it's this EDM forum that is really the dissemination, the synthesis and dissemination arm of this whole program, and it's run by Academy Health. So I've just got well, I've got some detail on those programs, but before I get into that, I'll give you the answer first. So this is what's hard. This is what each of those programs, each of those projects is grappling with as they try to create this infrastructure for large-scale comparative effectiveness research, and they're each grappling with this, and they're all coming up with lessons learned and trying to advance the field. And so it's things around the governance of the project, data ownership and data stewardship, who owns this, issues with data, the quality of the data, completeness, how the data are represented, the timeliness of the data, things like that. What's the technology that all this is built on? What are the privacy issues? What are the scalability issues? What are the generalizability issues? What are the sustainability issues? And then what are the training and manpower issues that go along with this? So these are the challenges. A few slides before there was the informatics challenges, but this is just kind of more broadly some of the challenges to having these kinds of these programs work successfully. So just to dive into them a little bit, just to give you kind of a sense of what's going on here, because I think this program here, this whole AHRQ program, I think is a good asset, and there'll be some lessons coming out of it. So these prospect studies, and prospect stood for prospective something, but the idea is these would be prospective comparative effectiveness studies. So the goal here was to create infrastructure. There are 6 projects, and you see the cohort sizes varied tremendously. The various research aims were comparing sleep apnea treatments, Alzheimer's medication treatments, diabetes care, hypertension care, asthma, and smoking cessation. And the various aspects of the infrastructure that have been put into place for these are things like natural language processing capabilities, community-based surveys and getting data that way, integrating with claims data, with payer claims data. There's some data warehouse technologies that have been experimented with, just various registries and being able to track things over time, issues of security, and then issues of data representation with ontologies. So that's what's coming out of that. In these scalable distributed research networks, the emphasis here is on collecting longitudinal data across diverse settings for diverse conditions. There's 3 here: cardiovascular disease in San Diego, asthma and hypertension in Colorado, and ADHD and weight loss also in Colorado. So just some of the things that are being done here. One of the data models, the Observational and Medical Outcomes Partnership, OMOP, which is a data model that was developed for kind of drug surveillance, adverse outcomes, post-marketing surveillance. That data model, which looks to be potentially promising, is being exercised in some of these. These are multi-state projects. Many of, at least two of them are multi-state. Again, integrating claims data, integrating patient reporting data, getting data over time, and PopMedNet, which is it's a library of tools for doing some of these kinds of analyses is being used, and these are large. The number of patients in the cohorts, from 500,000 to 7.5 million. So that's what's going on there, and then the enhanced registries. Two of these. Again, this is tracking data over time and focusing on peripheral artery disease and pediatric Crohn's disease. Again, multi-state, using some analytics platforms that are already out there. You might be familiar with I2B2 and Shrine. So these, I guess these projects are close to the end of year 2. These are 3-year projects. They're close to the end of year 2, and this EDM forum, they're collecting articles which will be published in a supplement of medical care at some point in the next 2 or 3 months, I guess, depending. And I think there's 21 articles, and you can see that on analytics methods, some of the informatics challenges, some of the data governance challenges, analytic methods, clinical informatics, learning healthcare system, and data governance again. So I think for folks who are doing work in this area, that these kinds of experiences and the lessons learned is going to be an important asset. So I just wanted to mention that. And this was a slide that actually they showed at one of their meetings, one of these EDM forum meetings. And I thought it was interesting because they call these things electronic health data initiatives, and they had them on a scale from horizontally from community care to research, and vertical from implementation to discovery, and the projects here, these enhanced registries, the data research networks, and Prospect, were kind of down more at the discovery end. But they just kind of laid out some of the other initiatives that are going on in this area, and I thought this was just kind of instructive, just to kind of show the number of initiatives that are going on. There's the Mini Sentinel project from FDA. The clinical effectiveness research pilots. There's something called the HMO research network, HMORN. There's DARTnet, which is a practice-based research network. There are initiatives going on for a multi-payer claims database. There's the PACER project, which is based here in New York State, funded by pharma and trying to bring data together from the local medical centers to create kind of an analytics platform. There's the Decide project from AHRQ, the developing evidence to integrate into decision making from AHRQ. The Observational and Medical Outcomes Partnership, which I mentioned. Other projects at the FDA. There's the Beacon communities that were funded by High Tech. Other things going on at the Office of National Coordinator. There's the SHARP project, which I think Mayo is leading to work on some of these techniques. So a lot of stuff going on in this area, and I think one of the questions is, are we building on top of each other as we're kind of going through all this, or are we just kind of running into the same brick wall around that list of challenges that I listed before? Okay. So I just want to say a couple of words about phenotyping. And again, I think especially for folks on the medical informatics side or the clinical informatics side, that this is, I think this is a poorly understood problem or a poorly appreciated problem. That, again, patients got CHF, patients got asthma, patients got that, what's the question here? But it is more complicated than that. If you're going to rely on claims data, that's one thing, but we know the claims data has its limitation. If we start folding in clinical data, then they start getting all kinds of nuances about the problem list and lab results and validating and exclusion criteria and things like that. And if you're going to say somebody's a diabetic, because you're going to give a rule that fires and you're going to interrupt the clinician, you might have a different threshold than you say, well, we're going to include this patient in a cohort study for public health, and we're going to analyze all of the diabetics. You might be a little more tolerant of false positives in the public health example. So, when you start scratching below the surface, it quickly becomes a non-trivial problem pretty quickly. There's a fair amount of work going on in this area. I just wanted to mention one initiative that's working on this, and I think they're doing pretty good work, and it might be indicative of just some of the things that might come out of things. So it's called the EMERGE project. So it's EMR and genomics. Again, trying to link those two. Organized by the National Human Genome Research Institute consortium to develop approaches that combine biorepositories with EMRs, high throughput genetic research. 7 members in this project thus far. They're listed there, and they've identified certain phenotypes that they're working on, again, to link to these biorepositories: cardiac conduction abnormalities, cataracts, dementia, diabetic retinopathy, lipid problems, height, hypothyroidism, lipids, peripheral artery disease, and type 2 diabetes. And they're looking at a variety of things: informatics issues, ethical, legal, social policy issues. Some of their work groups are listed here: consent education, regulation consultation, EHR integration, actionable variants, phenotyping, and genomics. And their phenotyping algorithms, when they've validated them, in general have 95% or better positive predictive value for the various use cases. And they're doing comparison across sites. Ostensibly, you'd like to have something that has validity across sites. Understanding the data fragmentation issues. So, if you're getting data from one institution and trying to do this, but as opposed to maybe getting data across a health information exchange, how does that change the kinds of things that are going on? And then this idea of phenotype-wide association studies. So rather than looking at the genetic variants in a given disease, look at a given genetic variant across diseases and things like that. And so the phase 1 is kind of coming to a close. There's been a phase 2 that's been chartered, and they'll be looking at pharmacogenomics issues, trying to relate that to EHR. So I think there are other similar projects that are going on, but I thought they were doing some interesting work, so I decided just to point to this one. So let's see, I think with that, I think I'm going to switch now and talk about health information exchange. So as Konstantin mentioned, one of the things I've been doing for the last about 5 years or so is I've been executive director of a health information exchange here in New York. known as NYCLIX, which stands for New York Clinical Information Exchange. And we've been trying to create an information, to basically to create interoperability among the medical centers here in Manhattan, and also some other organizations, not just the medical centers, but the visiting nurse service and some federally qualified health centers, with the idea that, you know, interoperability of health data can improve clinical care and also can enable some other things. And I'll give you an overview of this, and I'll especially make some comments about how a health information exchange might be able to support some of these research kinds of activities that we've been talking about, and also some of the challenges that we've found directly in trying to use NYCLIX for those kinds of activities. But before I wanted to just kind of preface the remarks about the health information exchange with these comments that I just made, because I think that, you know, we NYCLIX are not the only ones that are tackling this, and I want to show that out. So I just wanted to, you know, make sure that there was a focus on just, you know, the broader set of challenges around trying to realize the benefits of the potential that's here. So, changing gears. So NYCLIX is an example of what's called a regional health information organization. And, you know, the region in this case being New York City or Manhattan. And you know, the question comes up, you know, why do we have these things? Why do we have these regional health information organizations as an approach to trying to create interoperability? And you know, this model has its roots in about 2004, when the federal government created the Office of the National Coordinator, and they decided to create a strategy for advancing the use of electronic health records in general. And so the strategy in 2004 was that there should be a four-part strategy, really, that we should have EHRs. Everyone should have EHRs, what they called informing medical practice, that these EHRs should be interoperable. They should be health information exchange or interconnection. We should involve the patients, and we should make sure that whatever infrastructure we create supports the public health, and biosurveillance and things like that. So this was the strategy. So strategy is good. You know, money, no money. So there was no money that was given to this, and health information exchange was important, because if I'm a physician, you know, and I've already got an office and my office is running well, why would I put an EHR in there? You know, it's just going to muck things up. I got to log on, identify the patient. You know, so you know, I could just, you know, yell for my secretary. She brings me the chart. You know. So the idea of health information exchange was important, because if I have an EHR and I'm plugging into something, you know, now I have got like a window onto a broad set of data. Now maybe that EHR is of value. So the idea of health information exchange was important, because it increased the value proposition for having an EHR. So, you know, those things went together. But to have this health information exchange, there's challenges that need to be addressed, and there's, you know, what's the governance model, what's the technology, what are the privacy issues, how do you pay for this, how do you implement it, and because the federal government wasn't going to do that themselves, they said, well, you know, the regions should do all that work. And so they promoted this idea of regional health information organizations. And a lot of communities, you know, stepped up and said, yes, we'll do this. You know, we'll go on. And, you know, New York State especially jumped in at the state level and gave some funding to health information technology, health information exchange. Other communities did. And as I say here, by 2010, there were almost 200 of these functioning local health information exchanges, according to the eHealth initiative. But that's kind of why we have these things. So yeah, and so New York State, since 2006, they've invested a total of about $430 million through the HEAL program. So HEAL New York is the Health Efficiency and Affordability Law in New York. And it was a bond act, and it had it was for restructuring healthcare in New York. The majority of the $1 billion went to kind of bricks and mortar restructuring, but there was a significant chunk that went to health IT. And the idea was to create a 21st century health information infrastructure. That's what this was going to. I'll mention no other state has given as much money to health IT as New York, by close to an order of magnitude. So New York is really in with both feet on this one. And the funding went to supporting RHIOs and also electronic health record systems. And you can see here it was broken out into 4 phases. The first phase was just to demonstrate interoperability. It created the RHIOs. The second phase was to try to create a statewide architecture. The third was to encourage the use of what had already been implemented to support patient-centered medical homes in these new evolving health models. And the fourth phase was to support novel care models specifically for chronic disease with a mental health comorbidity. And when you combine mental health problems with chronic disease, it becomes a very big problem for the healthcare system. These kinds of patients just consume a lot of healthcare resources and have really poor outcomes. So targeting this particular kind of population, so like diabetics who have depression, or people with congestive failure who also have depression. It's like if you're depressed, you can't take care of yourself. Your CHF gets worse. You get readmitted. It's a vicious cycle. So there was a phase that was targeted specifically at that. But anyway, so this is kind of what New York State has done, and this is what's resulted. So across the state, there are about a dozen of these regional health information organizations, and you can see that there's one in Buffalo, and there's one in Rochester, and there's one in Syracuse, and there's one upstate, and there's one in Albany, and there's one in Binghamton, and here in New York, and there's one in the Hudson Valley, and here in New York City there are 5. There's one in the Bronx, and one in Manhattan, and one in Queens, and one in Brooklyn, and one Long Island. So we'll say a bit about that in a moment, but still, this is kind of what has come out of the New York State HEAL program. And so this is NYCLIX. The driving vision is that you've got a clinician who's caring for a patient, and today, or before we put this in, they have access to the data only from their institution, even if there's data about the patient elsewhere. But if you put in this capability, then they can have access to that data as well. So you have this clinical use case that's driving it. And there's an understanding that if you were able to do that for clinical purposes, you could use the same thing for other purposes like public health, quality reporting, things like that. And so just a couple quick facts about NYCLIX. It's a not-for-profit corporation. It was established in 2006. The mission is to improve care by creating an interoperable information infrastructure that supports innovative programs of care. We have a board of directors that's made up of the participants. It's a federated data architecture with a master patient index. 13 organizations are contributing data. The privacy model is that if I'm caring for a patient and I want to take data out of the exchange, the patient has to give me permission in writing. So that's the privacy model, and that's a New York State recommendation. It's not law yet, but that's the Department of Health recommendation for privacy models for RHIOs. It's been very modest, about $1 million a year in operations. We're functional. Physicians can view data via a web-based portal by identifying the patient and seeing that. And then we're also sending alerts. So we can detect when patients are admitted to one of the medical centers, and then we can let physicians in the federally qualified health center know, or nurses at VNS know. And so in addition to this retrieval, there's also this active messaging capability that's part of the program. These are our participants. NYU is a proud participant, played a strong leadership role in the development of NYCLIX. So you can see it's mainly medical centers, mainly in Manhattan. But as you look to the bottom of the list, there is the Institute for Family Health, which is a federally qualified health center, Visiting Nurse Service of New York, largest home health agency in the country, some nursing homes, and a Medicaid managed care plan. And you can see here that you can be involved either by contributing data or taking data out, and then also capturing the consent is a big workflow piece. So we track that as well. And this is what our portal looks like. There's nothing magic here. It's a results review application, like you've seen before. The only difference is that these are, it's a multi-institutional viewer. So this patient here has data from the Visiting Nurse Service, NYU, and also Beth Israel. These are the data elements that are in there. So it's uneven. We get registration data, lab data, radiology reports from everyone. And after that, it's a little uneven in terms of meds or other text reports. Some of the reason for being uneven, some of it's technical issues. People can't serve up the data easily. Some of it's financial issues. We don't have the funding to build the interfaces. But even anecdotally, the reports we're getting is that even with the data that are there, it's worthwhile. And just the current status is there's about 4 million patients in the system. So basically, since we set the system up in about 2009, that represents all the people that have come to at least to one of our members, because when they show up at the member, then they get registered in our system as well. So we've got about 4 million patients. About a little more than 10% have been to more than one of our members in that time. Patients who show up in the emergency room, about 30% of them have data elsewhere in the system. About 400,000 patients have given consent. When we ask the patients, they give consent about 85% of the time. The usage is modest because of, I think, largely because of workflow issues. It's a separate portal. And folks have to leave their EHR to go to this system and use it. We do have an active evaluation program. We have testimonials, but we don't have measurements of impact. But we do have an evaluation program. Things we're working on now, we want to integrate NYCLIX into the EHRs kind of with single sign-on to increase ease of access, and working on supporting care transitions, like inpatient to non-acute, and messaging and other collaboration tools. And one thing is, as part of this, trying to fix this fragmentation here in the downstate region, we are actually in the process of completing a merger with one of the other RHIOs, the Long Island RHIO. And we hope there'll be further consolidation. But we are merging with the Long Island RHIO LIPIX, and the name of the new organization is going to be HealthIX, Health Information Exchange. So if some of you have heard of NYCLIX, you might be hearing HealthIX going forward. So anyway, that's where we are. So I wanted to just talk for a few minutes, and this will be some of the last remarks I'll be making, about the use of NYCLIX for analytics. And so, some of the things we talked about before. So, we said the primary use case for NYCLIX was the clinical use case. I'm a clinician, I'm caring for a patient, I'd like to get this patient's data. But we understood that, that you could use this infrastructure to do other things, including these kinds of these analytics. But the observation is that the members of NYCLIX have been very reticent to use NYCLIX for these kinds of analytic purposes, for any kind, and whether it's operational or research or things like that. So let me just say a bit about that. Why are the NYCLIX members reticent to do that? So first of all, the participants in NYCLIX largely are large medical centers on their own. They have capabilities to do analytic types of things. They don't need another organization to do their analytics on their own data. They feel that their data has value, and this is my data. I can do research on it. I can get something out of it. Why would I give that to somebody else for them to give data, for them to get benefit from? You say, well, if you and you combined your data, you'd have this bigger thing. It'd be of more value. You could each use it. That's a bit of a squishy argument. They don't really buy that. They don't. They're not convinced enough that there'd be enough added value to do that. Then there's the issue of trust, and as I say here, RHIOs were developed to support the clinical use case, and the trust model was developed to support that. And so the NYCLIX members are willing to share their data if they know that you're going to be using it for clinical purposes. They'll trust you to do that, but just because they trust you to do that doesn't mean that automatically they'll let you do it for research purposes. And the trust for research is a different conversation than trust for clinical purposes. And we've tried it at the board level. My role as board chair, I try to advance that conversation, but it just, there's just apprehension. In addition, that there's competitive concerns. What will you learn about me and my patients that would allow you to compete more effectively against me? The questions come up. Even if you had the capability to do this, how would you decide? Well, what's an okay analysis to do, and what's not an okay analysis to do? You wouldn't want to, even if you said, I want to do this, but I just don't want to let my competitor have competitive information about me. How would you manage that? Who would decide? And things like that. So those kinds of questions are out there. And also, I think some of the financial models. Let's say somebody did do a research project with this shared database. How do the data contributors share in the rewards of that, whatever that might be. And so, ostensibly, we the RHIO could broker these conversations, but it hasn't been easy. I think the other piece is that even though that list of august organizations has been participating in NYCLIX, I'd say they've got a toe in the water. It's been viewed as an experiment, a bit of an R&D project. It's not a strategic project, really. It's a bit of a hedge against how some of these things are going to unfold. And there's been a lot of technical folks who've been involved. I think if you're talking about sharing data for research, that it's another level in the organization that needs to be involved and needs to support those kinds of activities and sponsor those kinds of activities. And then there's there's other hurdles. There's the privacy regulations around using a RHIO for research data and things like that. We've also talked about, does it have to be an all or none thing? So if these 3 organizations are willing to participate, but these 5 aren't, maybe we could just do it with 3, but we just haven't gotten that far. And then there's architectural considerations on whether you need to centralize data or things like that. So I think that's what I want to say. Just to kind of wrap up the the NYCLIX piece. I think there are intriguing opportunities from health information exchange, but I do think that that the whole field will need to mature, and I think the focus in health information exchange will be on clinical, exchanging the data for clinical purposes for the near term, and that exchanging data robustly for research purposes and some of those other questions we were talking about might take a while to unfold. So just rather than having a summary, I figured I'd close with some questions. What are we learning? Are we learning new things, or are we learning the same thing over and over again? Are there financial models for shared research? I think some of those questions would advance, or might create incentives for getting the ball down the road. Are providers willing at all to give up their own parochial interests for the greater good? Can we have that discussion? What would the public want? What would the people want us to do? And just to close with a quote, this is from Don Detmer, former CEO of AMIA, writing here in JAMIA. And he was talking a bit about privacy laws and how how privacy laws currently inhibit research, but I think it goes to some of this, some of the other aspects of some of this. Is, he says, without countervailing attention at the federal level to balance continuing restrictions, here in the name of privacy, we'll transform ourselves from a nation with great historic investment in the common good to a fearful, self-interested set of individuals without positive cognitive frames and social norms. So, this is potentially a very, important social program, social goal, but there are risks of having it kind of chopped up by some of these interests. I will stop there. I thank you very much for your attention. I'm happy to have discussion as much as we have time for. Thanks very much.